A little bit about Jay Sizemore. He's not just the mild-mannered guy that you see traveling through the hospital trying to take care of antimicrobial stewardship. He actually graduated from the Baylor School here, and it's the first time I'll use the word that he was valedictorian. He then went to undergraduate work at Duke University, where he graduated cum laude, and matriculated to the University of Tennessee College of Medicine, where he was AOA and valedictorian. From there, he decided he'd throw his hand in at Johns Hopkins for his internal medicine residency. And after leaving there, he went to the University of Alabama to do infectious disease fellowship and remains board certified in both of those specialties. He's on faculty with the Department of Internal Medicine and chairs the Clinical Core Competency Committee. He's had over 30 invited lectures and numerous publications. He served Erlanger Hospital itself in many capacities, including Chief of Staff and as a trustee of the board. And I can tell you he's been a friend of graduate medical education in many ways, and especially graduate surgical education in its pursuit to stay excellent in ways that you'll never hear about or know about when he was on the board here at Erlanger. So today we'll have our antimicrobial stewardship update by Dr. Sizemore.
Appreciate the introduction and the opportunity to speak to you all today. Just for those of you that I haven't met, right now we're a little shorthanded with respect to infectious disease. So just the logistics of how do you contact me. The easiest way to do it is via my cell phone through Tiger Text or Tiger Connect. I have two partners, Charlie Longer and Adam Souffleris, who occasionally cover for me when I'm out of town, but I'm always happy for you to reach out to me, and then I can pass it along to them if that's easier for you. Otherwise, you're going to call my answering service is going to call me, and then I'm going to have to call you. And for me, it just works out better if you just want to reach out to me directly. An additional resource that we have here is a clinical pharmacist that's specialty trained in infectious disease, and he's Kyle White, so he and I work together here. Very knowledgeable guy, and you'll see us usually walking around the hospital together. So again, appreciate the opportunity. Although we can debate some of the nuances of what I'm going to tell you today, everything that I'm going to tell you is really is fact. And the only reason I preface my remarks with that is that maybe I'm biased, maybe I'm paranoid, I don't know which, but this area of medicine seems to be where there is the most misunderstanding, and I hope I'm going to be able to explain to you why. So here's what our objectives are. We're going to look at the importance of antimicrobial stewardship. This is not something Jay Sizemore made up. This has been an effort here at Erlanger really over the last 10 to 11 years, but more importantly, an effort across the country to reduce the amount of antimicrobial resistance that we've generated over the last 7 decades. We're going to look at general principles to help improve antimicrobial stewardship in clinical practice. So how can you be a better steward of antibiotics as you're taking care of patients on a daily basis? And then finally, look at some specific situations that you could use stewardship principles in practice with patients that you come into contact with. So there's nobody publishing literature today that's saying we need to treat for longer or we need to treat with broader antibiotics. You will not find publications that saying that we need to do that. Probably the most, one of the most remarkable studies to the contrary was the Stop It trial in the surgical literature, where we found that we could treat intra-abdominal infections for 4 days after adequate source control versus what was typically a 7 to 10 day course. So everything in the literature now is moving towards shorter duration. How can we make diagnoses faster and limit the exposure of antibiotics to patients? So the bottom line, we have to look harder for reasons to stop or modify antibiotics than we do to start them, right? So anybody can write an order for vancomycin. I mean, that is so easy. Anybody can do it. It really requires no skill. And if you're going to do that and just leave your patients on those antibiotics, you might as well not do any cultures, because there's no way you're going to use your cultures to guide your therapy. So the question is how can we modify that practice, especially in patients who are not critically ill, to optimize outcomes? If we don't change our practice, we're gonna generate a post-antibiotic era, and in some situations, we're already doing that. For instance, over the weekend, I was on this past weekend covering a patient who had been at Erlanger, now at Park Ridge, who had a pan-resistant Enterobacter coming from his knee. No antibiotics, at least that were on the initial panel that we could use to treat this patient with. So it's not as common as it is in some places in the Northeast, but there are pan-resistant bugs, and then we're essentially left with telling family and patients, I hope your immune system kicks in, because we don't have anything to offer to augment that. So I like to use this editorial from the, or commentary from the New England Journal of Medicine. You'll notice it's dated January of 2009. So this explains why we're in the situation that we're in. So it starts out describing a 33-year-old in 1942 who basically dies of an overwhelming streptococcal infection. So if you could imagine maybe a teenager playing a high school basketball game, gets a severe floor burn, and subsequently gets a secondary infection that spreads to the bloodstream. In 1935 or 1942, we really didn't have anything to offer that patient. So along comes penicillin, subsequently a few other antibiotics, and we've got miracle drugs, right? We're saving people's lives left and right. And so every generation of physicians since that time has been taught, in general, about the benefits of antibiotics. And in my opinion, the risk of antibiotic use has been overemphasized. So the second patient vignette described in this article is somebody who has vancomycin-resistant enterococcal endocarditis in the modern era and essentially dies from that infection. And so that antibiotic use over time has generated those type of resistant bugs and these sorts of challenges that we face moving forward. So one of the risks of overusing antibiotics is generating resistance, and we'll come back to a few others as we move through. This was just another lay press article from the New York Times a couple of years ago. Many of you may have heard when there was an incredibly resistant E. coli that was resistant to colistin. Probably many of you have never used colistin, may not have ever heard of colistin. Colistin was an old antibiotic that nobody used primarily because of nephrotoxicity, but has subsequently been recycled, and people are now trying to figure out how to use it, because oftentimes that was the only drug left. And now this article describes an E. coli that's subsequently resistant to colistin. So if you want to know where our true threat lies currently with respect to pan-resistant organisms, it's with gram-negatives. Most of the lay press deals with MRSA, but as you all probably know, we've got plenty of MRSA drugs out there. So it's really the gram-negatives where we face the biggest challenge, especially in the inpatient arena. So this was a slide from the old Erlanger system of a quadriplegic who was back and forth between Erlanger and a long-term acute care facility, chronically vented, trached, and this was an example of another pan-resistant organism that had been generated over multiple courses of antibiotics. The reason I like to show this is, A, there were two bugs there. One of them happened to be a pan-resistant Acinetobacter, but B, this was a trach aspirate. And so this gets to one of our points of laboratory stewardship. If you have a patient like this who is chronically trached, the same holds true for chronic Foley's. If you're going to culture that patient through a tracheal aspiration, or if you're going to culture that patient with that old Foley catheter in, you can expect that culture to be positive. So it's not going to be a surprise. It's going to be positive. And so what are you going to do when it's positive? And so if you're that provider, again, and I'll come back to this, who likes to treat every positive culture that you get, well, be ready, A, to get a positive culture, and be ready, B, eventually to get an Acinetobacter that looks like that. All right, so we have to be judicious in our and methodical about our ordering of laboratory tests and subsequently about our antimicrobial use. So why is there a problem with resistance? So overuse and inappropriate use, this is driven largely by patient expectation. It's driven, as I've already alluded to, by provider education. And it's driven to some degree by defensive medicine. There's a perceived medical legal risk with withholding antibiotics. There's the issue of agricultural use, which is not really a topic for this discussion. And then there's also the issue of lack of available new antibiotics, which I'll speak to in just a moment. With respect to the medical legal risk, lawyers will see you for anything. And this is just an example. I just Googled lawyers and C. diff. And if you watch daytime television, it's full of commercials similar to this. But there are people out there who are looking, there are lawyers out there that are willing to look for inappropriate antimicrobial use that resulted in C. difficile infection and either colectomy or death. So if you think that there's a medical legal risk for withholding antibiotics, I would argue there is also now a medical legal risk with overprescribing antibiotics. And you should just be aware of it and balance whatever perception you have with respect to medical legal risk. This was a comment by a guy that I don't know. He's an ID doctor in Nevada, and he's talking about the issue of not having new antibiotics. And he says, I'll be the token curmudgeon of the forum and ask, do we really want or need new antibiotics? The question comes from a perspective of dealing with stewardship across multiple care settings and at national levels where we have antibiotic overprescribing, lack of transparency in reporting carbapenem-resistant Enterobacteriaceae, ongoing use in the agriculture industry, et cetera, et cetera, et cetera. The reality is the world has an abuse problem, and there is an argument that we are simply feeding the fire. Until we have true stewardship on the global stage, any new antibiotic will simply be abused and promote more resistance. The priority should be stewardship, not giving more drugs to the abuser. So this is not, this idea or concept of stewardship is certainly not going to go away. Now, if you're pharma, pharma is not very interested in developing antibiotics that somebody may be on 7 to 14 days of the entire patent life, and that hopefully good stewards will only use when needed. So the development of new antibiotics has slowed incredibly. So 15 of the 18 largest pharmaceutical companies are out of the research and development business with respect to antibiotics. Since 1987, no new antibiotic class to treat pseudomonal infections. That was the year that imipenem was introduced. Since 1987, only one new antibiotic class, and that's somewhat arguable, to treat gram-negative rod infections. That's tigecycline. Again, not a very good drug. Fraught with black box warnings, huge volume of distribution, will not treat bacteremia well, and doesn't cover Pseudomonas. If you look at from 80 to 84, 19 antibiotics approved, 2000 to 2014, only 13 approved. Our professional society, the Infectious Disease Society of America, has tried to address this issue with our legislators to try to incentivize drug companies with longer patent lives, other incentives to try to develop antibiotics, but certainly not been fruitful, and most of the new drugs that have come out have been targeting staph and not the true threat right now, which are the gram-negative rods. So in 2017, again, about a decade after the Infectious Disease Society of America came out with its initial guidelines with respect to antimicrobial stewardship, the CDC released this report with respect to antibiotics in the United States, progress and opportunities. So I just took a few of the introductory facts from this report. So it makes the argument that antimicrobial resistance is a public health emergency in this country, that we have 14 million bacterial infections annually. In 2002, 5% of these were drug resistant. In 2014, meaning 2 or more classes of drugs, 11% of them are resistant. So this is 1.5 million drug resistant infections annually, contributing 23,000 deaths and $2.2 billion. So it doesn't, if you look at cost, if you look at patient death, or you look at sheer numbers, we're seeing an increase in the number of resistant infections. And if you've been around, you've certainly seen this. So this was an article taken from JAMA in 2014, just to further kind of bring this issue forward. So how big is the inpatient problem with respect to stewardship? So up to 50% of inpatients get an antibiotic during their stay. So every day at Erlanger, our census, you can pull this up on Epic, is somewhere in the low 500s typically. So 250 or so or more of those patients are going to get an antibiotic during their stay. 25% of them, or about 125, will receive 2 or more antibiotics during their stay, and it's been estimated, at least according to this article, that 20 to 50% of this antimicrobial use is inappropriate. Again, to drive home this point that this is not new, this is a slide taken from the CDC in 2002. Okay, this is looking at 12 steps, a 12-step program to prevent antimicrobial resistance in hospitalized adults. 6 of the 12 steps highlighted in teal here, 5 to 10, have to do with using antimicrobials wisely. This is the IDSA legwork that has been done and guidelines that have been published with respect to antimicrobial stewardship. In these guidelines, it basically drives home some pretty simple points. This is a patient safety issue. It's designed to prevent misuse and overuse of antibiotics, which is rampant. It's designed to help deal with the issue of increasing antimicrobial resistance, which is rampant. And as a secondary outcome, it will help us deal from a hospital system standpoint with the budgetary constraints. And if you look at most pharmacy budgets, somewhere between 20 and 25% of the budget are spent on antimicrobials. So the CDC, in addition to the report that they released in 2017, also published some elements on how you do antimicrobial stewardship in various settings. These are the core elements. These are small and critical access hospitals, of which our system has 2. This is nursing homes, and this is outpatient antimicrobial stewardship. So this effort goes across the spectrum of patient care. The National Quality Forum took these guidelines released by the CDC and basically developed a how-to guide. You want to Google how to be a good antimicrobial steward, read this 50-page playbook, and you'll have it down. Antimicrobial stewardship has also, as of January the 1st, 2017, become a requirement. It is required to participate in Medicare, Medicaid. It's required to be accredited by JCO or the entity that Erlanger now uses, D&V. So this is a requirement as we move forward. So we need you as a partner to drive excellence here at Erlanger. So we've been fortunate since about 2008 to have administrative support for stewardship that's allowed us to use evidence-based principles and teamwork. We report up through the P&N committee, which Dr. Smith chairs, and we've had good support from that committee and subsequently good support from the MEC. It requires everybody, every provider who's ordering antibiotics, we need them on our team to support this effort, and we feel it's a value-added service to the medical staff and their patients. We do some chart auditing with feedback, and this is where this is a note that you might see from us in Epic. Again, there's a disclaimer at the bottom. Some might argue that this is actually a curbside consult, but essentially what happens, we have some screening mechanisms in place. where we're trying to look at as many people on antibiotics as we can, but some of the higher risk antibiotics we certainly pay more attention to. And so this was from, you can see, I think the 23rd of last year. This is a person who got put on vanc, ceftriaxone, acyclovir, and dexamethasone versus a nosocomial fever. Apparently, they also had some altered mental status. They had just finished 8 days of ceftriaxone 2 days ago. Okay, so it's unlikely that ceftriaxone is going to be effective in somebody who's just been on it for 8 days, right? There were no CSF studies that were able to be obtained secondary to cerebral edema, although the clinician was documenting a concern with respect to meningitis. The patient had AKI. So, you know, we want to be at least cognizant of the fact that vancomycin can cause, can worsen renal function. We have some blood cultures that are negative, some repeat cultures that are pending. We just make a note that nosocomial meningitis is rare without a shunt. And certainly the patient's not going to, it would be almost unheard of for them to have herpes encephalitis. And if you suspect a gram-negative infection, you probably need to use something that's broader than ceftriaxone, given that the patient has just finished 8 days of it, right? This is just logic. And it turns out that ID is really fairly simple and fairly logical if you just get the basics down. Again, we can't see we don't know everything that you know about the patient. We don't know, so we're occasionally we're gonna miss something that you're gonna know, and you're gonna say, well, how could they say that? And that's fine. Send me a Tiger text or track me down. We're always happy to hear feedback and generate discussions. In the MICU, we've actually started having some little mini stewardship rounds to try to work with the medicine critical care guys. So stewardship and use. So how can you be a better antibiotic steward? So again, I've already mentioned this to some degree. You got to acknowledge that a lot of what you were taught in medical school and residency about antibiotics was either incomplete or wrong. Okay, I acknowledge that on my own training. You know, this was something that I had to learn. Use the fever tab in Epic. I'm going to show that to you in a second. It helps with an antibiotic count. It helps give you a general idea of what's going on with respect to infectious disease with your patient. De-escalate or stop antibiotics quickly. There have been many that have argued for a 48-hour antibiotic timeout. So does it make sense today, based on the information that we have today, do we still think that what we did 48 hours ago makes as much sense as what we're doing now? Is there a compelling alternative diagnosis where we might be able to alter our therapy? Are there culture data available where we have opportunities to de-escalate? So I would suggest that you ask yourself, any patient that you have on antibiotics, this question every day, but certainly on new patients, there have been many people that would argue for the 48 or 72-hour timeout. Check outside cultures and count outside antibiotics. So we don't want to count just the antibiotics that patients have here at Erlanger, because we accept a lot of transfers, right? So they may have had 4 or 5 effective days of antibiotics before they ever got here. Also, again, an issue that we've really kind of harped on the medicine residents about. It's going to be embarrassing if I have to come tell you about a positive culture. If you're documenting in your note, well, the blood and urine cultures are negative here, and your patients have been on antibiotics for 4 days at an outside hospital. It's not surprising that the cultures are negative here. But if I call that outside lab and they have E. coli bacteremia and they're on, that's AMP sensitive, and they're on vancomycin and cefepime here because nobody's called the outside lab, and we often get incomplete records, as you know, then that's a missed opportunity, right? We want to be able to get the information that's out there, and it's a pain to some extent, but usually it takes, 90 to 120 seconds to contact a microlab and for them to give you the information. I would prefer that, that you get in the habit of getting that faxed here and then using Haiku to get it scanned into the media section of Epic, because it makes things easier. So hold antibiotics in clinically stable patients where culture data is incomplete. Not as big an issue on the general surgery side. We have more of an issue with that in some of the surgical subspecialties, but we would appreciate your partnership in that. Don't treat asymptomatic bacteriuria. Again, it's going to be, I'm going to show you a slide at the end that suggests some antibiotic never events, and treating asymptomatic bacteriuria would be one of those. So again, you can't be that person who treats every positive culture that you see, or you're potentially going to be harming patients. All the guidelines with respect to most of the inpatient issues in infectious disease are available on idsociety.org, and I'll show you that in just a second. So this is the fever tab. Again, if you haven't used it, you should try it. It's pretty good. It gives you some longitudinal data with respect to fever, white blood cell count, antibiotics, and cultures. So we use this all the time, and it can kind of help you count antibiotic days, kind of help you when the patients were on antibiotics, off antibiotics, when the cultures were taken. Again, I mentioned this a little earlier, but examples where you can always expect a positive culture, a urine culture in an asymptomatic patient with a chronic indwelling Foley, with altered mental status or cloudy malodorous urine. I'm going to explain in a few minutes asymptomatic bacteriuria is increasingly common in nursing home patients and older adults, along with catheterized people. And then wound culture of an asymptomatic patient with a chronic venous stasis ulcer or chronic sacral decubitus ulcer. Those cultures are going to be positive, and they're not helpful. All right? So I know we're all taught to do something. We're all taught to do something. And believe me, we want to do the right thing for our patients. But swabbing a venous stasis ulcer in the wound clinic or in the ED is not going to be helpful, and it's going to be positive, and it's going to lead to antimicrobial resistance. So that's why I put this disclaimer at the bottom. I mean, recognizing that you do not have control over all cultures that are collected or the reasons for doing so, you still do not have to be that provider that treats all positive cultures. You will do patients harm. There is really no debate about that. So what I want to do over the next few minutes is give you some general principles of antibiotic use. And this may sound oversimplified, but it's really all about the logic that should drive your practice with respect to antimicrobial use. So when to start antibiotics, right? So when the stakes are high, severe sepsis, we know about the sepsis protocol, the sepsis bundle here. One of the big issues is getting antibiotics in a timely manner. Suspected bacterial meningitis is another circumstance when we would obviously begin antibiotics. We need to make every attempt. It is critical in my mind to collect appropriate cultures prior to antibiotics, and that's something that we often fall short on. But again, the stakes are high. We're going to start antibiotics. When else are we going to start antibiotics? When there's reasonable certainty about the diagnosis and appropriate cultures have been collected. All right? So this makes sense, right? When not to start antibiotics. So a clinically stable patient with undifferentiated fever. So we're talking in general, when I'm just generically, when I'm talking about clinically stable patients, I'm talking about floor patients, okay? So somebody spikes a fever, their vital signs are otherwise stable, pan culture start vancomycin, or pan culture start ceftriaxone, or pan culture start vancomycin. That's not what we need to be doing. Clinically stable patient with leukocytosis. So we hear this term spike. Well, their white blood cell count spiked. It went from 11 to 15. All right? And let's say you start antibiotics, and the next day it's at 10. So what does that tell you in your mind? You can't help it. I can't help it. It must be the antibiotics, right? It's gone. It went up from 15. I did something about it. I gave antibiotics, and now it's back down to 10. It must be the antibiotics, right? Well, so I'll tell you, I hold antibiotics all the time in this situation, and it goes back down. And I say it's variation, right? So you can't, it's true, unrelated oftentimes. And so you can't fall in to that trap. So clinically stable patient where culture collection is not complete. And I'm going to harp on that a little bit because as a surgeon, you might not think about what that means on the backside, But if I'm committing a patient, especially with an orthopedic infection or a sternal infection, if I'm committing them to 6 to 8 weeks of toxicity of antibiotics, I want to make sure that I get the right antibiotic. And the only way I'm going to get the right antibiotic is if I get great culture data. So if you get me great culture data, and then I'm able to narrow that antibiotic down to cefazolin rather than vancomycin, that we're going to be doing, we're going to be benefiting that patient. Asymptomatic bacteriuria, don't treat it. Be looking for reasons not to use antibiotics in bacteriuria. All right, so specific situations where antibiotics can be held and routinely are not while cultures are obtained. So diabetic foot ulcers. So when you're rotating on the vascular service, we need your help with this, right? And I'll come back to that. Wound swabs are not helpful in this situation. Discitis osteomyelitis, right? These patients are usually relatively stable. We get blood cultures. We get our interventional radiologist to get us some disc material. We may occasionally ask our neurosurgeon to get us an open biopsy. But we're committing these people to 6 to 8 weeks of antibiotics. We want to get it right. Sacral decubitus ulcers, you guys help us out with those occasionally. Interestingly, there's an increasing amount of literature that suggests that even with osteomyelitis in the setting of sacral pressure ulcers, if there's no plans for coverage, antibiotics are of limited utility. So it may have an opportunity to say, let's get it debrided, let's be aggressive with the local care, but if we're not going to flap it, maybe we don't need to use antibiotics. Bilateral cellulitis. So infections other than pneumonia generally are not bilateral. All right, so a lot of these patients are going to have venous stasis disease and probably just need to elevate their legs. Hand abscess. So we struggle with this to some degree on the hand service. You know, they like their antibiotics early. They want to see if it responds over 24 hours. But usually if there's plans for surgery and there's an abscess there, the way to treat the abscess is drainage, get the good cultures, and then start your antibiotic. And then suspected septic joints, again, at least we can get an aspiration. And if they're stable, if there's plans for fairly expedited washout, we could probably hold them until after our operative cultures are collected. So diabetic foot ulcer, if you're on the vascular service where deep infection is suspected, you know, this is the way we need to do it. CBC, BMP, SED rate, CRP, plus or minus blood cultures. We don't need UAs on patients with diabetic foot ulcers, right? I mean, we've got to change the culture around here. I'm not saying, certainly not implicating this group, but we've got to stop that culture of a patient coming into the ED with a diabetic foot ulcer and we order UAs. We want to get an MRI. We want to hold antibiotics. We want to get an MRI with contrast, especially if no bone's exposed. We don't want to use superficial swabs. And we want a deep culture with removal of all infected bone if feasible. If you remove all the infected bone, then it's reasonable to use something like doxyaugmentin empirically for 5 days while you're waiting on your cultures. Okay, the doxycycline, as I'm going to tell you in a second, is a safe MRSA drug. It covers 91% of our MRSA here at Erlanger. All right, it's C. diff friendly. All right, so good MRSA coverage, some gram-negative, a little bit of anaerobes. Obviously, you're missing Pseudomonas with this particular regimen. But again, the surgery has taken care of the bulk of the problem. You're just mopping up a soft tissue infection. It doesn't matter if you're wrong. Even if you get it wrong, you just shift your antibiotics. If you say this foot's not salvageable and you're going to do a BKA later in the day or tomorrow and the patient's clinically stable, they only need perioperative antibiotics. You're going to take care of the infection with the surgery. And then certainly glucose and local care. So this is the way that I would like to see us approaching diabetic foot ulcers. Okay, it's very frustrating when they come in the ED, they get admitted by the nocturnist, and they get put on vanxosin. I mean, that's like the worst thing that you could do for that patient. Most people don't come to the hospital one day after they get a diabetic foot ulcer. Their pulse is normal, their blood pressure is normal. Usually they're afebrile, their white blood cell count's normal. There is just no emergency to getting that patient antibiotics. You're doing them a disservice, in my opinion. So when to stop antibiotics? So when the patient's better, right? So subjective, you know, we've got in-house procalcitonins now, and some people are trying to use that to figure out when to stop antibiotics. But in general, everything is shifting towards shorter durations. There are some data now with 3 days for pneumonia coverage. There's some studies in Europe that are looking at 3 days for meningococcal meningitis is enough. So everybody's looking for a way to treat for shorter durations. When an alternative non-infectious diagnosis is secured, okay, so if some old person comes in with altered mental status and you work them up for a stroke and they have a stroke, their bacteriuria is probably asymptomatic. We can explain why they were altered. They had a big stroke. So they probably didn't come with a stroke and a UTI. So I'm looking for opportunities not to do damage to this person who just had a stroke. And then when to stop also is supported by IDSA guidelines, the drugs package insert, and newer evidence-based studies published since the last iteration of the guidelines. It's just common sense. You just got to know where to look. So when to change antibiotics? Right, so when clinically significant organisms are not being covered, okay, we're going to do that. When clinically significant organisms can be covered by a more narrow spectrum agent. So this is going to be an antibiotic never event, okay? If you leave a patient with AMP-sensitive E. coli on Pip/Tazo, that is a threat to patient safety. That is unnecessary. And so what are the responses I've heard? Well, the patient's getting better. They're getting better on Zosyn. Why would I possibly change the antibiotic? They're getting better. Well, they'll get better on ampicillin too. You know, we've got data to support that now. And if you leave them on, there was just a published paper from out of University of South Carolina on this issue of using anti-pseudomonal beta-lactams for Enterobacteriaceae bacteremia. If you compare the group of patients who received less than 48 hours of anti-pseudomonal beta-lactams versus the group that received greater than 48 hours of anti-pseudomonal beta-lactams, there was a three times risk of getting C. diff. All right? So, I mean, if that's what you're into, is generating, you know, increased risk for your patient to get C. diff, leave them on Pip/Tazo. But it's every month now in our literature, more and more data are coming out with respect to how we're going to be better antimicrobial stewards. So let's say you've got a patient on antibiotics up in TI and they're getting worse. All right, so that the condition's worsening is suggestive of infection. You think that the coverage that you've got on the patient now is not adequate, right? So you want to broaden the coverage. A-OK, right? Critically ill patients, sick in the ICU, right? But if you're going to do that, please get some cultures, right? We just don't want to expand coverage without having new information to then act on 48, 72 hours down the road. All right, and then when the PO route becomes available. What antibiotics to start? Probably no surprise to you, the top line, Vanc Pip/Tazo, is rarely, if ever, the answer, okay? Why is it not the answer? Well, the biggest new reason that it's not the answer is there's increased associated nephrotoxicity when Vanc is used with Pip/Tazo compared to other beta-lactams, like cefepime, like ceftazidime, like meropenem, all right? And so that's the number one reason. And most of the time, that's not even a good combination anyway. Are there really lots of infections where you're worried about MRSA, Pseudomonas, and anaerobes? Okay, so most of the time you're not worried about all three of those. Occasionally you could be, but most of the time that's not an issue. So I would encourage to not use that combination or look for reasons not to use it. Vanc, Pip/Tazo, and Levaquin. So I'll throw this out there to one of the residents. What does Vanc cover that Pip/Tazo doesn't? What are you getting? What clinically significant bugs are you covering with Vanc that Pip/Tazo doesn't cover? Anybody? MRSA, right? What was the other answer? So it's unusual to see AMP-sensitive Vanc it's unusual to see an AMP-resistant vanc-sensitive enterococcus. Occasionally you'll get it, but Pip/Tazo will cover the 99% of our E. faecalis that are AMP-sensitive. Our E. faecium are where we run into most of the trouble with ampicillin resistance, but almost half of those are also resistant to vancomycin. So most of the time, if you're looking for additional enterococcal coverage, you would probably want to go with something like linezolid. So MRSA is the big one. Most of our coag-negative staphs, actually a higher percentage of our coag-negative staphs are resistant to methicillin compared to Staph aureus. It's about 65% of our coag-negative staphs versus about 55% of our MRSA. So again, coag-negative staphs tend to be wimpy bugs. All right, so it's not usually not an emergency to give vancomycin for coag-negative staph. So really what you're getting is MRSA coverage. So Pip/Tazo, you're getting strep, you're getting staph, you're getting MSSA, you're getting most enterococcus, you're getting Pseudomonas, most gram-negatives, and anaerobes. So incredibly broad antibiotic. So the next question, what does levofloxacin cover that Pip/Tazo doesn't? Right? We use these antibiotics all the time. So if you're going to use these two together, what are you trying to cover with the levofloxacin? Because we just talked about how broad Pip/Tazo was. Right. Well, some people like to double cover Pseudomonas, right? So the brief answer is atypical. So if you've got a community-acquired pneumonia where you're suspecting an atypical infection, that's one situation. So Stenotrophomonas. So occasionally when we hammer patients with antibiotics, we'll generate a Stenotrophomonas. So when you think about Stenotrophomonas, you think about Bactrim, levofloxacin, ceftazidime. Those are going to be the three drugs that we're going to typically use. Occasionally we can ask for minocycline sensitivities. But if you're thinking that you're going to cover a run-of-the-mill gram-negative with levofloxacin, and again, unless you've hammered your patient with Pip/Tazo, it would be very unusual to see a Levaquin-sensitive Pip/Tazo-resistant gram-negative rod. So again, a lot of people argue about double covering Pseudomonas. Pseudomonas, you're not going to see one that's sensitive to Levaquin typically that's resistant to Pip/Tazo. So if you wanted to get some additional Pseudomonal coverage in a critically ill patient, that would be the one circumstance when I would use probably a single dose of an aminoglycoside like tobramycin. Okay? Probably one of the most important points of the lecture is we've got to look at penicillin allergies. Okay, and I'm going to explain to you why. This is a reference if you want to look at the review article from the review article in Clinical Infectious Diseases that summarizes the nephrotoxicity associated with vancomycin. This is looking for ways to generate less vanc use with using MRSA nasal PCR swabs, and I know there's some research and interest in the room from that, but at least from this study of 11,000 isolates, there was over a 99% negative predictive value when using the swab and excluding MRSA pneumonia in ICU patients. Penicillin allergies. So again, I'm not a huge fan of UpToDate, but UpToDate can be awesome for quick reference, but I do love the review article that's in UpToDate with respect to penicillin and beta-lactam allergies. So somewhere, depending on what study that you look at, 15 to 20% of inpatients report a beta-lactam allergy. 90% of them are not real. Okay? So let's just do the numbers. Take 1,000 people who report a beta-lactam allergy or penicillin allergy. 100 of them are going to be penicillin allergic, and 2 to 3% of those would have a reaction to a cephalosporin or a carbapenem. All right? Tolerance of other beta-lactams is valuable information. So that's one of the ways we can use EPIC efficiently. I can see every antibiotic that a patient's received in the EPIC system. Just go to meds, unclick current meds, and filter by antimicrobials. So if I've got somebody that I really want to use a cephalosporin on and they report a penicillin allergy and I'm scared and I don't want to believe this fact that only 3% will cross-react, and I can see that they've been given Keflex or ceftriaxone before, feel really comfortable with using it in that setting. So use EPIC to your advantage. So why does the 60 to 90 seconds it takes to investigate a penicillin allergy matter? Before I get to that, how do I investigate it? Well, what's your penicillin allergy? Well, my mom told me I was allergic. That's not an allergy, okay? Well, I tolerated it when I was a kid, and then when I was a teenager, I took it and I got a rash. Probably had mono, okay? You don't tolerate penicillin? Oh, can you tolerate amoxicillin? Oh, yeah. Yeah, I took that bubblegum flavored liquid all the time when I was a kid. That patient's not penicillin allergic. Do you take Augmentin? Oh, yeah, I take Augmentin. You can trick them because you don't use psyllin, right? So you don't use psyllin, but you say, can you take Augmentin? Oh, yeah, I tolerate Augmentin. That patient's not penicillin allergic. Okay, I do this all the time. You can skin test them. You can send them to one of our allergy colleagues, but they're not going to be allergic. And if somebody just has a rash, I'll give them, and they need a cephalosporin, I'll give them a cephalosporin 100% of the time. No issue. Right? We just watch them. But what happens? What happens in the real world? Here's 4 studies published in the last 2 years. If you've got somebody with cancer in the hospital and they report a beta-lactam allergy and they're requiring antibiotics in the hospital, they're going to do worse. Increased cost, increased length of stay, increased mortality. If you look at the consequences of avoiding beta-lactams in patients with beta-lactam allergies in this study, there's lower rates of clinical failure when beta-lactams are used. If you look at surgical site infection risk, there was a 50% increased odds of surgical site infection in beta-lactam allergic patients. All right, so we really need to be brave about, be brave but not stupid, be smart about getting these penicillin allergies off, because the worst thing that we can do for our patients is what these patients have heard for the last 40, 50, 60 years. My doctor told me never to take a penicillin, right? Never. Or anything related to penicillin. And most of us are afraid. We're not going to give them a cephalosporin. Lots of times we may give them ace-trionam, right? We think that that's a safe antibiotic for penicillin allergic patients. Better be sure you're covering a gram-negative, because Azactam has no gram-positive coverage, no anaerobic coverage. So this is important, and it's pretty easy to do, and I find that you're doing good for your patients. So know where to go when you don't know the answer. We've got a local antibiogram that's published on the intranet. We're a little behind right now. The one that's posted is 2017. With the transition to EPIC, we're hoping to have the 2018 up soon. I've already mentioned the IDSA website society. You've got Kyle and I here most of the time, and we're ready for your questions and then up to date. So this is the IDSA website. There's a idsociety.org. There's a guidelines tab here. They're all free via PDF. Specific situations and pathogens, just want to drive this home. Asymptomatic bacteriuria, long-term Foley catheter use, 100%. So 100% of those cultures are going to be positive if you send them. Again, you guys have been the leaders in the trauma ICU as far as something that we now are trying to adopt hospital-wide, of taking out catheters before sampling urine in patients where we suspect urinary tract infections. Candida. Candida is important for surgeons. First thing to know is that Candida in the sputum and urine almost never need to be treated. Candida does not cause pneumonia except in essentially bone marrow transplant patients. Okay, Candiduria can be an issue, especially if patients have hardware, but in general it represents colonization. So if you're in the ICU and you've had a patient who's been on antibacterials, you can expect colonization of the urine, and if you get a urine culture that's positive for yeast, it's usually not a big deal, and it's usually not what's driving the nosocomial fever. So I would not hang my hat on Candiduria as a cause of nosocomial fever, especially in the setting where there's no hardware. With that being said, Candida in the blood always requires therapy. It may be a contaminant. It may be a colonizer, but the mortality risk in patients who are candidemic is about 25%. The stakes are high. So it may be a contaminant, just like Staph aureus can be a contaminant, but we're never going to ignore Candida in the blood. So 14 days after the first negative culture is your therapy, is your duration of therapy, and fungal cultures are usually unnecessary to detect Candida in the blood. Many of you may be familiar with the Candida score because you are the ones that deal with these sorts of patients. So when I'm escalating or when I'm starting antibiotics in an ICU patient, when do I consider empiric antifungal therapy? And so this is published in the critical care literature over a decade ago. But if somebody's got severe sepsis and they have any of the following three: multifocal colonization, they're on TPN, or they have multiple abdominal surgeries, they probably warrant empiric antifungal therapy while you're waiting on blood cultures. Okay. This gets into the weeds a little bit. If you can remember this, it's probably all that you would need to know with respect to species of Candida: albicans, Paropsilosis, tropicalis, glabrata, and krusei. The first three are typically fluconazole sensitive. Glabrata has higher resistance rates to fluconazole, but the resistance can be overcome with higher doses. Krusei is intrinsically resistant to fluconazole. There have been some treatment failures with Paropsilosis and echinocandins, but in general, in the ICU, we would start with the echinocandin, and our formulary echinocandin is micafungin. So if you were to do that and you were to get one of these species back, we would, in most settings outside of fungal endocarditis, we would de-escalate to fluconazole. You don't have to wait on the sensitivities because the therapy is probably going to be over before you get your sensitivities back. C. difficile. So I know there's also some interest in the department in C. difficile, so it's really difficult. Again, loose stool in a floor patient is typically not an emergency. Okay, and so we've put in some BPAs into eChart with respect to looking at this and trying to encourage providers to be thoughtful about ordering C. diff. In general, nurses should not be able to order C. diff, and we would appreciate it if you would take heed of the BPAs because we think they're important. Stop inappropriate use of PPIs for stress ulcer prophylaxis. I don't know how big of an issue that is on y'all's service. Certainly relatively common on the hospitalist service. You know, in patients especially that aren't on narcotics, stopping scheduled stool softeners is probably a reasonable thing to do. It's on a lot of the order sets. And again, it's just so tempting when those patients develop diarrhea to just order a C. diff. And oftentimes we don't look at the fact, well, they've gotten, you know, all sorts of stool softeners in the last few days. Obviously, if you do have a diagnosis of C. diff, stopping the other antibiotics if feasible. Avoid clindamycin in nearly all situations. That's important. Test of cures are clinically unnecessary. Expect relapse, colectomies, and death. Again, just a reference to a meta-analysis speaking to the safety of doxycycline with respect to C. diff. It's actually C. diff protective. So I would never use clindamycin. Where do you guys usually use clindamycin? In the setting of necrotizing infections. Where does clindamycin work? It works at the ribosome to decrease toxin production when you're expecting group A strep. What other alternative agent also works at the ribosome at the same spot? Linezolid. So actually, you can get MRSA coverage, reduce toxin production, better 100% MRSA coverage compared to about 70% with clindamycin, and not expose your patient to the C. diff risk. So again, we've often replaced clindamycin, vancomycin actually, with linezolid if it's a perineal infection, either Zosyn or Unison, and if it's a group A strep infection of an extremity, penicillin. Appropriateness of C. diff testing, again, probably don't want to get into the details of the Bristol stool chart, but we really want to look at type 7 stools as the types that we're sending down. We don't really, the lab hopefully will refuse form stool, but we don't want to send form stool down. At another facility about 25 miles down I-75, one of the doctors said, well, just put some water in it and mix it up because they really wanted their C. diff test, but we really want to test liquid stools. Many of you may be aware, as of earlier this month, we've changed our paradigm for C. diff testing yet again, and this is largely driven by what's in the C. diff guidelines, because we're not good laboratory stewards, and so we're a little loose in our C. diff ordering. So before we just did the PCR. PCR is incredibly sensitive. We felt like we were picking up on a lot of false positives that we're then having to report to hospitalcompare.gov. So then we went to a two-step algorithm where you do a GDH and a toxin assay. If they're both positive, it's positive. Both negative, it's negative. If one's positive, one negative, it goes to a PCR. Still think we're getting too many false positives. So generally the toxin's negative and the PCR's positive. So now what we're doing as of August the 6th, if you order a C. diff test, the PCR is going to be done first. And if the PCR is positive, it's going to reflex to a toxin. And if the toxin positive, that's the terminal test. That's a PCR positive, toxin positive. No guidelines does 250 milligrams exist. So severe, 500, run-of-the-mill, 125, nowhere does 250 exist. There's no pharmacokinetic data to support a 250 dose over a 125. Fidaxomicin is FDA approved. It's generally not used in the inpatient setting. It's primarily related to expense and no clinical advantage over PO vancomycin. The one advantage that fidaxomicin has is in non-NAP1 strains, there's reduced number of recurrences. So if you want to use fidaxomicin, then you probably need to call the lab and figure out whether or not you have a NAP1 strain or not. And then stool transfer is a stronger presence in the current iteration of the guideline. I alluded to the antibiogram, so if you open up the internet, go to document libraries, go to pharmacy support library, and then you have your antibiogram there that you can access. So that's on the internet. These are just some updated sensitivities. If you're a kind of person who likes levofloxacin for UTIs, you might be surprised by these numbers, but that's not going to be usually a good choice, empiric choice for E. coli UTIs. In fact, a first-generation cephalosporin that we typically use for gram-positive infections has better coverage than levofloxacin. Enterobacter, this is the one counterintuitive point that I make about stewardship. I'm always talking about let's narrow, let's narrow, let's narrow. But serious Enterobacter infections, either in the blood or in the lungs, if you use ceftriaxone, you can actually generate resistance while the patient's on ceftriaxone through AMP-C production. Cefepime is stable against AMP-C production, so serious Enterobacter infections that even where it looks like ceftriaxone sensitive use cefepime. We've talked a little bit about Pseudomonas already. ESBL UTIs, most of us when we hear ESBL, extended spectrum beta-lactamase producers, we're thinking carbapenem. Right now, carbapenems are our last line of defense against gram-negative rod, so we want to look for other alternatives, especially in patients with more minor infections like UTIs. So beta-lactams concentrate in the urine. Oftentimes, these are sensitive to Bactrim or fluoroquinolones. So when you've got ESBLs in the urine, look for alternatives to carbapenems. Double beta-lactam therapy, again, rarely a problem here, but it's frowned upon. So there's two scenarios where we would use double beta-lactams, enterococcal endocarditis, and empiric coverage for meningitis where listeria coverage is needed. Know a few holes here. I'm happy to share the slide set, but this makes sure that you remember that if you've got an AMP-sensitive enterococcus and your patient's been on ceftriaxone for a UTI, you say it's AMP-sensitive, it must be ceftriaxone sensitive. We got to rid you of that misconception. The enterococcus is intrinsically resistant to cephalosporins. I'm going to skip over the rest of these for now. I wanted to come back to this. These are antimicrobial never events. Again, this is one author's commentary on how we might structure what the biggest patient safety threats are. So antibiotic use for a non-susceptible organism after ID and susceptibility, right? We got to look at our susceptibilities. We don't want to have a drug-bug mismatch. And again, not a huge issue here. The second never event has to do with de-escalation if you're not de-escalating appropriately. The third issue has to do with antibiotic prophylaxis that exceeds national guidelines. Again, generally not an issue with the general surgeons, more of an issue with subspecialty surgeons. We see facial fracture prophylaxis, open fracture prophylaxis, lumbar drain prophylaxis. We see post-breast implant prophylaxis, post-pacemaker prophylaxis, where we're having patients go home on 5 to 7 days of antibiotics. That's not supported in the literature. Antibiotic use for viral upper respiratory tract infections, and then again, asymptomatic bacteriuria. So I'll close with this. Apologize for rushing a little bit at the end. I think stewardship is an initiative that will drive excellence that everyone should demand within a healthcare institution like Erlanger. And you can, if you start to look at these principles and buy into the principles, I really feel like that you increase a safer environment for your patients that require antimicrobials. I'll stop there and take any questions.
Well, I'd like to thank Jay for the provocative, thought-producing things. We have one question because we're over time. Anybody in particular? Dr. Maxwell, you grabbed the microphone.
Yeah, appreciate that strong message, and I'd like to say I think we try to be compliant with stewardship for the most part, and we just like to let you know the critical care team recently had a journal club on the nephrotoxicity associated with vancomycin, and we're trying to do better with that. Combination of antibiotics. Another quick comment, we were looking at the nasal swabs to reduce vancomycin coverage, and we found the sensitivity of that wasn't what it needed to be, and so we've stopped using that to guide therapy on empiric coverage. The one question I wanted to ask you about was there's probably not a week that goes by anymore, particularly in the warm months, where we don't get some morbidly obese diabetic with some kind of necrotizing perineal infection. And I was just wondering if you could maybe elaborate a little bit on what the empiric coverage for that might look like and how long we should be doing that after surgical debridement.
Sure. So typically with severe soft tissue infections of that nature, we recommend 14 days of antibiotics. That's somewhat arbitrary. I like linezolid unison up front. If we feel like that if there's a patient who's been in the hospital a lot or maybe at risk for more resistant organisms, linezolid zosyn up front, quick surgical debridement, get some operative cultures, and then try to de-escalate antibiotics from there, usually converting over to PO to complete a course.
Thank you very much, and we'll defer all other questions you personally.
Okay.
So, my question.